Hello to all. So welcome back to the YouTube channel MEDICO'Z Factory. So today we are going to study the general medicine, in which we are going to study about the respiratory medicine. So this is an important concept, and also you should know the basic treatment lines. So today we are going to study is pulmonary medicine, and in that the topic which we are going to study is respiratory failure. So respiratory failure, what is it? It is defined as pulmonary exchange fails to maintain normal arterial and oxygen levels and carbon dioxide levels. So whenever the exchange of gases is there at the arterial level, at that time normal oxygen and carbon dioxide levels are impaired. So first of all, let us know what is the normal oxygen level at the arterial. That is 95 plus or minus, you can say 5 mm of Hg. If we talk about the carbon dioxide, it is 40 plus or minus 2 mm of Hg. Now let us start with the respiratory failure. It was a definition. Now type 1, that is hypoxemic respiratory failure, or we can say that low oxygen at the level of arterial blood. So what is mainly, there are 4 types, but which are main and discussed and asked in the exam is type 1 respiratory failure and type 2 respiratory failure. So first let us discuss the type 1. So hypoxemic respiratory failure, that is known as type 1 respiratory failure, is characterized by an arterial oxygen tension, that is PaO2, is less than 60 mm of Hg, that is the normal is 95, or a low arterial carbon dioxide tension. That is the definition of type 1, that is low PaO2. If it is less than 60, it means it is in the state of type 1. Now how is type 1 further classified? Let us see. First is acute respiratory failure, that is any disease are classified into 2 criteria, acute and chronic. Anything is up to the 3 weeks, then we can term it as acute. More than 3 weeks, it will go to the condition known as chronic. So what are the reasons for acute respiratory failure? If you find any patient, it can be acute asthma, pneumothorax. We know very well, pneumothorax, that is the condition in which the air leakage between the space of the lungs and the chest wall. Then pneumonia, acute pulmonary embolism, that is I think the blockage of the lung artery. ARDS, that is acute respiratory distress syndrome, where there is disease condition. And pulmonary edema, where there is a collection of excessive fluid in the lungs. Now if the acute respiratory failure is there, you have known ABG ratio, arterial blood gas. So what will be the changes in it when there is acute respiratory failure? What are the clinical identifications? PaO2 level will severely decrease. PaCO2 level can be normal or it can decrease. The pH can be normal or it can decrease. Now you should know first normal pH. pH is 7.4, that is normal. And HCO3, that is bicarbonate ion, normal ratio is 24 plus minus 2 millimole per liter. It can be normal in the acute respiratory failure. So this was about the acute reasons. Now we will discuss for the chronic. Now what is the reasons for the chronic respiratory failure? First is chronic pulmonary embolism. Another is the chronic fibrosis, where the lungs tissues become thick and stiff. So it makes hard for the lungs to absorb the oxygen from the bloodstream. Now right to left shunt, a cardiac disease. Chronic chest wall diseases, neuromuscular diseases, and chronic pulmonary edema. These all are the reasons for the chronic respiratory failure. Now what is the ABG ratio? PA2 can be low down, while in the acute it can severely low down. PaCO2 level, that is carbon dioxide level, it can be normal. pH level can be normal. Bicarbonate level can be also normal. Now we will discuss the treatment line. This was that what are the reasons and that. Now how will you treat the person with the type 1? So first is treat the primary conditions. Whatever the things are there, like give oxygen and maintain that. Next is high concentration oxygen, 40 to 60% we can provide to the patient. And whatever the things are taught in this lecture, this will be useful for the students to write in the exam session as well as for the practitioners too. And those who are doing the residency, it will be helpful them as well. Next is high flow nasal cannula, HFNS-NC oxygen. Now this therapy is carried out with an air or oxygen blender, active humidifier, single heated tube and nasal cannula. 4 things are required, and it is able to deliver adequately heated and humidified medical gas as it follows up to 60 liter per minute. That is HFNC oxygen. So how is it? Let us see. See, this type of the things are provided. Here there will be hole which will be with the cannula with the ergonomic design for application of higher flows. Then here it will be a breathable film delivery house that reduce fluid condensation if there is any kind of the patient is having edema. Then heated respiratory hose due to which the patient will humidify the area. Then in the machine there will be the O2 input with the integrated mixture analyzer and automatically filling water reservoir. Now this will be an inbuilt sensor that will eliminate the temperature, and integrated flow generator which will deliver up to 60 liter per minute of oxygen. This is HFNC, remember very well. Next, if you give the HFNC treatment, what are the physiological benefits? It will reduce the anatomical dead space. Then PEEP, what is PEEP, you know na? Positive and expiratory pressure. What is it? That will remain in the airways at the end of respiratory cycle, and constant FiO2. In the only next slide we are going to discuss for the FiO2. Now oxygen flow rate and FiO2. What is it? Let's see. There are 2 important things to consider when delivering supplemental oxygen to the patient. One is oxygen flow rate you should keep in your mind, and one is FiO2. See, oxygen flow rate is a number that we dial up on the oxygen flow meter. Remember very well. Usually between 1 to 15 liter per minute. This depends on the conditions of the person, where it is the 4:1 rule, that every 1 liter of oxygen flow adds 4% to FiO2, mainly with the cannula. What is FiO2? It is defined as the percentage or concentration of oxygen that a person inhales, fraction of inspired oxygen. So whatever the person is inspiring the oxygen, that ratio plus 1 liter of oxygen we are delivering. So 4:1 ratio is seen. Next is atmospheric air that we inhale on a day-to-day basis is made up of 21% oxygen, 78% nitrogen and 1% trace elements such as argon, carbon dioxide, neon, helium and methane. This you can just remember. So this was about oxygen flow rate and FiO2 ratio. Now PaO2 and FiO2 ratio. What is it? This is very important factor. Remember. Now PaO2 FiO2 ratio is the ratio of arterial oxygen partial pressure to fractional inspired oxygen. We have already seen FiO2. So both of the ratio, arterial oxygen partial pressure to the fractional inspired oxygen. Now what is P represents PaO2 in the arterial PaO2 from the ABG. F represents the FiO2, the fraction of the inspired oxygen when the percentage is given expressed as a decimal. So if you write 40% of oxygen, then FiO2 will be mentioned as 0.40 in the decimal unit, and P is divided is equal to F is equal to PF ratio. So they will write like this. So P will denote PaO2 and F will denote FiO2, where FiO2 will be written in a decimal way. So when you deliver 90% is their PaO2 on the 40% oxygen, 90 is the ratio of the oxygen. So when you divide, so it will be 90 divided by 0.40. So you get is 225. So it is generally the normal ratio of P to PaO2 to FiO2 ratio in the patient. A PF ratio of 2 to 5 is equivalent to PO2 of 45 mm of Hg which is significantly less than 60 mm of Hg on a room air. Clear? So next, if PaO to FO2 is ratio is used, then it is a clinical indicator for hypoxemia. Remember this very well. If any kind of condition is there, PaO to FiO2 ratio is clinical indicator. See, anyone is living at a sea level, then normal is greater than 500 mm of Hg. Here it will be Hg, not mg. So if any condition where there is less than 400, that is hypoxemia, less than 300, then you can state the respiratory failure condition, and less than 200 then critical respiratory failure, but it is at the sea level. Okay. Now PF ratio should not be used to diagnose acute or chronic respiratory failure. So suppose the patient was on acute and it is developing the stage of chronic, at that time you cannot see the PF ratio because it would be quite creating a disturbance chart flow, value flow. Since many patients with the chronic respiratory failure already have a PF ratio is less than 300, where PO2 is less than 60 in their base stable state, which is why they are treated with a chronic supplementary home oxygen. So sometimes you will find that although there is a chronic respiratory failure and the PF ratio is less than 300. That is the reason why you should not use the PF ratio during the chronic respiratory failure. So this was all about type 1 respiratory failure. Now we are going to discuss the type 2 respiratory failure, where low PaO2 and elevated PaCO2. So this type of respiratory failure occurs as a result of alveolar hypoventilation and results in the inability to eliminate carbon dioxide effectively. So what is alveolar hypoventilation? Insufficient ventilation, that is leading to hypercapnia, that is increase in the partial pressure of PaCO2. So hypercapnic respiratory failure, you can also say type 2 is like that, is characterized by PaCO2 is greater than 50 mm of Hg. Hypoxemia is common in patients with hypercapnic respiratory failure who have breathing room air. So who are the patient of type 2? You will see hypoxemia commonly. Remember that. Type 2 respiratory failure may be further classified as either acute or chronic, like the same way we have seen in type 1. So what are the compensation or inability if the type 2 is there? Acute hypercapnic respiratory failure develops over minute to hours. Therefore pH is less than 7.3, and chronic respiratory failure develops over several days or longer, allowing time to renal compensation and increase in the bicarbonate concentration. So it can develop in the minute to hour, and the ratios of the bicarbonate level or pH can vary it, and the pH is usually only slightly decreased. This is the compensation of the type 2 respiratory failure. Now what are the acute respiratory failure reasons? Tracheal obstruction, massive pneumothorax, massive hemothorax, that will be the blood collection in the pleural space. Drugs like diazepam and opiates, brainstorm strokes, Guillain-Barré syndrome. In this your immune system attacks the nerve. It is viral or bacterial infection where your immune system attacks your nerves, and polio. These all are the reasons for acute respiratory failure in the type 2. Now what is the ABG ratio? PO2 will be decreased, where PaCO2 will be decreased, of course, because it is type 2. pH can severely decrease and bicarbonate level can be normal. This is the clinical finding which will help you to determine whether it is acute or chronic with the reasons. Now if we talk about the chronic respiratory failure, one is chronic obstructive lung pulmonary disease, COPD, central sleep apnea, that is apnea is a breathing disorder where the person feels abrupt awakening. We can say shortness of breath, insomnia, and chest wall deformities. Now what is the ABG ratio? PO2 will be decreased, same PaCO2 can be increased. Now pH here can decrease or it can be near normal, but bicarbonate level will increase. So this is the main difference between acute and chronic, because in acute it was normal while in chronic it will increase. So next is treatment. So how will you treat this type of the respiratory failure? First is the primary cause. Second is continuous low concentration oxygen at a rate of 1 to 2 liter per minute. You can try this. Then non-invasive ventilation. Remember this. Like HNFC, this is non-invasive ventilation. Or bi-level positive airway pressure, BIPAP. Now non-invasive pressure ventilation is referred as NPPV also or NIV also, that is positive pressure ventilation delivered through a non-invasive interface like nasal mask, face mask, nasal plugs rather than endotracheal tube or tracheostomy. You will not use this both method, then you will use this one, that is NIV. Bi-level positive airway pressure delivers both, that is inspirative positive airway pressure IPAP and expirative positive airway pressure EPAP. So first year should be that we will maintain the concentration oxygen, and then you can try NIV through a mask for that. This was about the treatment line for type 2. Now what are the physiological benefits? Like we have seen in the HFNC also, that it will increase the anatomical dead space decrease. Now what are the physiological benefit of NIV? First is the augmentation of the alveolar ventilation. So it will increase the space, which will revert acidosis and hypercapnia. Also alveolar recruitment will be there, which will increase the FiO2. And if the FiO2 will be increased, the level, we have seen the difference, then it will reverse hypoxia. Reduction in work of breathing and respiratory effort or fatigue. Another is chest wall stabilization. If the chest wall is stable, then if any kind of presence of trauma or surgery related to chest can be stabilized. Another is reduction in left ventricular afterload. That will improve the LV function, because sometimes it has to contract more to overdo the afterload. And another is counterbalance the respiratory workload, which will decrease the respiratory muscle effort. If the respiratory muscle effort will decrease, it will help to maintain alveolar ventilation and it will create the exhaustion of lungs. So these all are the benefits of NIV. Now how you will come to know that whether you should proceed or not for NIV? First is dyspnea, that will be moderate to severe, that is shortness of breath. Another is tachypnea, where the breath will be greater than 25 per minute. Tachypnea means abnormal rapid breathing. Okay. Now increased work of breathing, where the accessories muscle like diaphragm and will be used, and you can see the pulse lift breathing. Then hypoxemia, where the PaO2 FiO2 ratio will be less than 200 mm of Hg, because normal ratio is 2 to 5, we have already seen. Then moderate hypercapnia, that is PaCO2 level is greater than 45 or less than 92. Hypercapnia and hypercapnia is same. Hypercapnic encephalopathy, where the patient will have confusion, low signals, no signals. If it is not improved in 1 to 2 hours, then patient should be intubated. Remember this very well. Moderate acidemia, where pH is less than 7.35. So these all are the indications. Positive pressure ventilation is delivered through a mask. So if you are delivering NIV, we have already seen it is delivered through mask. NIV enhances the breathing in acute respiratory conditions by arresting fatigue in the breathing muscles. Another advantage is it can be applied intermittently for short period, which may be sufficient for reverse the breathing problems experienced in a severe acute asthma. So if any kind of asthmatic patient is there along with the respiratory failure, then you can try NIV, because you can provide it for a shorter duration to reverse back the symptoms of asthma. Now what are the contraindications, that in which conditions you should not give NIV? One is the coma, another is cardiac arrest, respiratory arrest, and any condition which is required immediate intubation. At that time you cannot prefer NIV. And suspected pneumothorax or undiagnosed pneumothorax. So remember that if any patient is having the history of respiratory failure associated with pneumothorax, then never ever go for NIV. And other contraindications, which are rare but you can still see, is cardiac instability, that is shock and need for pressure support. Ventricular dysrhythmias, that is brain and heart signals, rhythms are disbalanced, and complicated acute MI. In these conditions also you cannot go for NIV. Another is GI bleeding, where you can see intractable emesis, that is where the vomiting will be unavoidable. Severe vomiting will be there. Or uncontrollable bleeding, which is inability to protect airway. Or impaired cough or swallowing. Poor clearance of secretions like mucus and all. Depressed sensorium. There is sensor effect and lethargy. This is the GI bleeding. Rare NIV contraindications. Next is status epilepticus, where the person will have seizures. And potential for upper airway obstruction, where there is extensive head or neck tumors or any tumors with the airway compression or angioedema, that is a painless swelling under the skin, or anaphylaxis causing airway compromise. So what are the initial IP or EPAP settings? We have seen it will deliver the both bi-level. So what are the settings you should do when you give NIV? This all is the clinical knowledge. So try to gain very well. So it is helpful for the resident, interns, practitioners and everyone. First start at 10 centimeter water or 5 centimeter water. Then keep the pressure less than 8 centimeter water. But 4 centimeter is not advised. Why? Because it is inadequate. So either keep 5 or 8. Or initial adjustment to the tidal volume of the lung, that is 5 to 7 milliliter per kg if it is IP or EPAP. Now subsequent adjustment, this was the initial. After giving initial, if you think the condition is worsening or needs any kind of more adjustment, then what you can do? You can increase the inspiratory pressure by 2 centimeter if it is going in the hypercapnia. After starting the initial treatment, and still if you feel that the condition is not getting better, then and then only do that. Then also you can increase EPAP by the 2 centimeter and IPAP also, but in the condition of hypoxemia. Maximal IPAP limited to 20 to 25 centimeter water you can increase, but avoid in the condition like gastric distension or if the patient is feeling discomfort. Or maximal EPAP limited to 10 to 15 centimeter water. Remember this very well. Or backup respiratory rate is 12 to 16 breaths per minute. Now what are the predictors for success? Like if you are giving NIV, then how will you know that NIV pathway is correct or not? First is that PaCO2 level will be greater than 8 mm of Hg. It will the pH will also get improved, and the respiratory acidosis either will be reversed or you will see the condition getting more better. And what are the predictors for the failure of NIV? Although you are giving NIV, and then you in the which condition you should stop the treatment? That is severity of illness. Patient is going in the acidosis, hypercapnia, acute physiology or chronic health evaluation. APA-CHE2 score higher than 20. This is a score which is measured. Or level of consciousness, that is neurological score is greater than 4. That is the patient is going in the stuporous. That is either it is slow response, or you can say the patient in the condition known as near consciousness. Or vigorous stimulation is required or inconsistent to follow any command. Encephalopathy score is greater than 3. That is a major confusion, daytime sleepiness or agitation. And Glasgow Coma Scale score, GCS, remember this, that is less than 8. These all are the predictors where you will see that NIV is getting failed. So remember very well. Or failure of improvement within 12 to 14 hours of non-invasive ventilation. Now what are the complications for NIV if you provide? One is the pressure ulcers or necrosis. Another is facial or ocular abrasions, that is injury. Claustrophobia or anxiety, agitation. Air swallowing with the gastric or abdominal distension, which will lead to vomiting or aspiration. Hypotension if hypovolemic patient is there. These are the complications you will see in the. Then aspiration. Oronasal mucosal dryness. Remember very well, because it will create the dryness and itching in the nose. Raised ICP, this is the emergency condition. Also it is the complication, but Rest recipe is the emergency condition. Why? Because it will start the internal bleeding leading to brain stroke, high BP or brain infection, and increased intraocular pressure in the eye, and impaired communication and nutrition. Now, predicting NIV failure in hypoxemic patient. Now, if your patient is already in the condition of hypoxemia, then how will you predict that the NIV is failure? The first which was discussed is common. Now, before starting the treatment, the symptoms are like acute respiratory distress syndrome, altered mental status, shock, high severity scores, copious secretion, extremely high respiratory rate, or severe hypoxia instead of although you are giving oxygen. Now, after you start NIV, what are the factors you will see? Still there will be the excessive air leakage, breathing asynchrony will be there in the ventilator, tolerance will be low, or you will see any kind of neurological impairment. And after 60 minutes, that is after an hour, you will see that no respiratory rate is reduced. It is same. There is no improvement in pH, no improvement in oxygenation, no reduction in CO2, and signs of fatigue. So after an hour, if you see all of the following symptoms, it is the NIV failure in a hypoxemic patient. And NIV failure in the hypoxemic patient, the HSUR score is measured. How? Heart rate for H, acidosis for A, consciousness GCS scale for C, oxygenation for O, and respiratory rate are the predictors in the NIV in the hypoxic failure. So if you are suspecting any of the hypoxemic patients, then see the HSUR score. Like, what are the heart rate category? If it is greater than 121 or less than, then it is 0 to 1. Like pH, GCH, PO2, FiO2. So you can predict like heart rate is less than 120, so the 0. PO2 FiO2 ratio you can say 151 to 175, then 3. GCS scale is measuring 15, then 0. And the respiratory breath rate are less than 30, then 0. So the ratio is 3. So HSUR's ratio is 3. This is how you can measure. So HSUR is potentially useful beside tool for prediction of NIV failure. And HSUR score accurately predicts NIV failure in patient with the hypoxemic respiratory failure in the single center study. So what is the normal? That is greater than 5 at an hour for HIV highlight patient is at risk of NIV failure. So if any ratio is greater than 5, then you can say that the treatment in the hypoxemic patient for HIV failure is significant. So here it was ratio was 3. So you can say that the rate of NIV failure is not that low. Now intubation or mechanical ventilation. If NIV fails in the respiratory failure. Now what are the indications for the intubation? First is pH is less than 7.20 or 2 occasions at an hour, or hypercapnic coma where the GCS score is less than 8 or PaCO2 level is greater than 60 of mm of Hg. These are the indications where you should intubate the patient, or PO2 level is less than 45 mm of Hg, or cardiopulmonary arrest. Now more the reasons, like respiratory rate, breath is greater than 35 or less than 6 breaths per minute, tidal volume is less than 5 milliliter per kg. Blood pressure changes are there where the systolic pressure is raised by 90 mm of Hg, that is less than, or oxygen desaturation, that is less than 90. Although you are providing supplemental oxygen and still the ratio is low, then you should intubate. And hypercapnia where there is greater than 10 PaCO2 or acidosis. And obtundation. What is obtundation? That is reduced level of alertness. And diaphoresis, that is excessive sweating due to any kind of health conditions like MI or any kind of drugs effect. In that also diaphoresis is there, or abdominal paradox. So this was all about the respiratory failure. Do subscribe the channel and like the video, and it will be useful for the clinical knowledge as well. In case of doubt, you can use the comment section. Thank you.